Hello everyone and welcome to our fourth session of our Palliative Care in RACHs webinar series. Today we're focusing on the management of end-of-life care patients. I'd also just like to acknowledge the lands on which we're meeting on today. I'm on Wiradjuri country in Orange and Gemma is on Wiradjuri country in Dubbo. I would like to extend that respect to any First Nations people present in our meeting today and any First Nations people present to the land on which we're meeting on. So I'd like to introduce Gemma to everyone that's joined us today. Gemma holds 29 years experience working as a registered nurse within the New South Wales Health Department. Areas within health that Gemma has worked have been intensive care, high dependency, cardiac unit, emergency, oncology, and now within the palliative care team. Gemma has worked as an agency nurse in various locations around New South Wales, Queensland, Northern Territory, and even overseas. Obviously, Gemma has completed a Bachelor in Nursing, but has continued her education by completing numerous postgraduate certificates in ICU and palliative care. Gemma is very passionate about healthcare and delivering the best outcome for her patients and families. When she's not at work, she's usually outside or home renovating. She's a newly transformed runner with big dreams of completing a marathon next year. Best so far is half, which is still pretty good effort. Gemma can also often be seen at Bunnings gathering supplies for her next reno, painting rooms with colourful paints and murals. Just before we move on any further and I hand over to Gemma, I'd like to just do some housekeeping. So our presentation today will go for around 30 minutes and we should have 15-minute time for question at the end, but please feel free to put your hand up, take yourself off mute and turn your camera on if you would like to ask Gemma any questions throughout the presentation. At the end of our session today, there is a QR code that I'll ask you to complete an evaluation form for today's session as well. That gives us a bit of an idea on how we've achieved our learning outcomes and where we might focus our next few topics on. Okay, Gemma, I'd like to hand over to you.
Thanks, Hayden. Afternoon, everyone. Thanks for joining me this afternoon. So today I just want to really make this, as casual and as comfortable as possible. So yeah, definitely feel free to raise the hand and if you have any questions along the way. Got a lot to cover as normal, we all try and shove a lot into a small amount of time. But I guess my main aim today really is to talk about our learning goals, which is to identify the needs of what the patient needs at the end of life and what their key stakeholders, which is their important loved ones. Muted now?
All good, Gemma. Yeah.
All good. And the key stakeholders' expectations at end of life as well. We want to try and increase your confidence in having end of life conversations with residents, but also with their families. I want to talk about nursing care and responsibilities at end of life and symptom management. I think as that little quote says there, the goal of end of life is to optimise the patient's quality of life in the treatment of their disease and ensure that they die peacefully with comfort and dignity. So that's our main aim at this stage in someone's life. Hayden, do you mind just going to the next slide? I think just to start with, I just wanted to talk about a little personal experience. I think most of us have had someone who has passed away. It was one of our loved ones. And I was just going to share my experience. It was 20 odd years ago. So I was sort of a newish, only 9 years into nursing. Most of my experience in nursing by that time had been in ICU, so quite acute, and also just looking after other people's family members, not my own. And this was my father who passed away. He went from a very fit, robust man to being diagnosed with AML, and by 4 months he had deceased. So it was quite a rapid decline. I can remember the death like it was yesterday, so I can still remember it 20 odd years later. And what I remember of that night was no one actually spoke to us about what dying looked like, and all I can remember is some of his agitation and his noisy breathing. And it wasn't until I've sort of gotten into palliative care at a later date that I really understand that he probably did have a relatively good death, but it was that lack of knowledge of what to expect and what was going on that, you know, I guess even 20 years later, I can still remember it. So how someone dies is very, very important, not only for how the patient or the resident is, but for those loved ones that have that ongoing memory of it as well. Okay. So I guess one of the main things that are so important in end-of-life care is communication. So communicating with the resident, communication with their key stakeholders, whether that's family, carers, their best friend, whoever their key people are, and having conversations with them. And this leads you to ensure very good end-of-life care. So what we aim to do, and what I think is a very good practice to do, is to start conversations of end of life way prior to end of life. So we know residents come into aged care facilities and they will often, they're going to die there. That's their home. They're going to stay there until they pass away. So we know that's going to happen. And so having those conversations earlier allows for a much smoother transition into that end-of-life care, because everyone's aware of what the plan is, what the goals are, and so then it's less stressful when you actually enter that end-of-life phase. So what I encourage people to do is to set patient-centered goals early. So have a think about the resident, have a think about what their health conditions are and how they're likely to deteriorate as they go on. So, for example, someone with dementia is probably going to have a slower decline. They're going to obviously decrease their oral intake. They're going to decrease their mobility. They're going to have swallowing difficulties, as opposed to someone who's got COPD. They'll probably have more breathlessness, maybe more anxiety driven. They won't be able to move as much. They might get more chest infections. So having a little think about what their health history is and what that decline or trajectory of decline is likely to look at, and discuss that with the resident, discuss that with the family, so they're not surprised when these things start to occur. It's also good to start, as I said, those conversations at end of life prior to end of life. So ask them, so with that planning of what we're going to do in that phase, ask them questions like, what matters most to you? Who's important to you at this time? Who do you want to be there, you know, when you're in that dying phase? Is there anything in particular that you want to happen at that time? Do you want clergy representation? Do you have cultural or spiritual needs that you want to have met at that time? I would also, prior to, if you can, time permitting, prior to that end of life phase, have those conversations about funeral directors and informing them why it's important to know who would be their preferred funeral director, and, you know, are they for burial, cremation? So then they understand that we need to know this so we can organise the appropriate paperwork, that the resident can be taken into care by their preferred funeral directors. So it's about having all those things in place prior to having, you know, this occur. The other thing to do, I think, is reassess these goals regularly. So often, you know, people come in and now they're living longer times within the RAC environment. So what they had when they came in on their advanced care directives or how their health status was at that time will change over time, or likely to change over time. So reassessing those goals, re-looking at the advanced care directives. Is it still appropriate for this person to go to emergency department? if they have COPD and there's nothing further that, that medically can be offered to them. So just having a bit of a think about what the benefit of transfers would be for them as their conditions decline, involving the family still in regards to having these discussions, having these talks about, when you come in, this was our goals, but now we've seen that things have deteriorated a little bit. Now we're going to have another chat about re-looking at what we need to do to make sure we meet your needs and make sure that, you're comfortable during your decline. The other thing, as I said, is to involve those key people. So, you need to get consent from the resident on who they want to be involved with these conversations, but having that next of kin or that the key person that they have in their care journey is very vital, because I think some people who take on the role of next of kin or enduring guardian, that decision making at end of life can be quite heavy to make for them. So if you involve them from the get-go, they're well aware also on the goals of care, on the actual residents' wishes. So they are part of that conversation, and it's no surprises to them, when we reach that stage. And as I said, just be very open, honest with all communications. We can only divulge what we know sort of here and now, and the likely trajectory of things, but just being honest and open and communicating with the family and the resident is just vital to making it a very smooth transition. And as the quote there says, the finality of death is always the greatest fear for families, even when they actually know that the death is going to occur. So it's just, that final, that's there's no more. That's a big fear. Hayden, we'll just move on to the next slide. It can be really difficult talking to people about end of life care. It's a fear of lots of us, and it does take a bit of a skill. But I think the more you do it, the better you become at it as well. And there's loads of resources out there, which I'll sort of touch on in a little minute. But I think, as I said a couple of times, communication, huge driving force, having good communication and providing good end-of-life care. So really having those honest, open communications, explain and educate to the resident and to the family of what's happening now, but also what's likely to happen in the future as things progress. Also explaining, if we're at that end of life moment, what the signs of dying look like, the cognitive changes, the breathing changes, what the person will look like as they get a little bit closer to their death, pain, agitation, and explain how you're going to, manage those situations. Try not to use too much medical jargon. It gets very overwhelming when you do use all those sort of technical words. So, breaking it down to what people, pretty common language that people understand. And I also would encourage you to have two-way conversations. So impart some information, stop, listen to what they're saying as well. So it's that two-way street, because when you listen, you can actually pick up quite a lot of information rather than just ongoing talking like I'm doing now, just ongoing talking. But yeah, listening as well. It also, it builds up that rapport when you have that imparting information, listening, that communication. It builds up a rapport with the family, which can only help at end-of-life care as well. If you need to impart some information that is pertinent to the patient's care, there's the teach back method. So what you tend to do there is provide the information to the person and just ask them just to repeat it back to you. So basically just say to them, could you just repeat that, what I've just said back to me, so I can just check that you understood what I was, trying to tell you, because sometimes I don't explain things well, or however you want to put it. But it allows you to make sure that they're hearing what you're saying, and then if you listen and it's not quite right, you can reiterate and deliver that information to try and make sure the message is gotten across. You also want to be an active listener, so listening to what they are saying can give you so much insight into their thoughts, their concerns, any issues. They might not say I have pain, but they might divulge it in other little ways, like, oh, you know, since my fall yesterday, I just don't want to get out of bed. Well, you know, you can investigate that a little bit more. So just listening to what they're actually responding and what they're actually saying. The other thing that's okay, and especially when you talk about sensitive information, is to stop and pause and have silences. It's okay to do that because people need time to be able to digest the information. And, you know, crying and getting upset is also very, you know, it's acceptable. It's okay to be upset talking about these difficult conversations. There are lots of resources out there. I've just really briefly just sort of put up there just the little names of the little resources places, but you can access them online, and I'm pretty sure most of you would be aware of most of these anyway, but they have lots of little education sessions and to be able to tap into and to become more confident with having these conversations with people. But I think the main thing is to, you know, do it and do it often and practice it, because it is something that RAC staff are dealing with on a constant basis. Like it's part of your business, I guess, talking about end of life care. We might just go to the next slide, Hayden. Does anyone have any questions so far about what we've talked about? Does anyone? I don't see any hands raised. Must be hum along okay. We'll just move on to the nursing care and responsibilities at end of life. As I've said, you know, a lot is communication. So mainly we want to support the resident and the family. So we communicate both to the resident in the bed and also any key people around. You want to provide them with dignity and empathy. So be gentle with them, talk softly and calmly. Talk to the patient when you're providing care, even if they can't respond back. Also, part of that support is being an advocate for that patient or that resident as well. So you're the main carer at this time. So if you have any concerns about how that person is at this end of life phase, any unmanaged distress or symptoms, then you should address this. You should bring that up, whether that's with your in charge or whether that's with the GP, but you should look at being that voice for that person in the bed if there's something that you're concerned about. Explain how you will look after to the family, how you will look after their loved ones. So explain to them that, you know, you might want to give them some space. You might not be in here all the time, but I'd encourage you, you know, to buzz if you need anything. I'll pop back in a couple of hours, just so they know the routine and they're not thinking, oh my God, they're not coming in. So just talk to the family, explain how you're going to care for their loved ones. Also explaining any of the paraphernalia that's around. So if there's oxygen, if there's a syringe driver, just explain what that does so they're well aware of what's going into their family member. So, you know, talk about the medications that are in the syringe driver. You know, we have morphine for pain relief. We have some medication there for some nausea. We have something to keep them nice and relaxed and settled. Just explain, you know, as you go. You don't have to do it every day, but just so they understand what you're doing. Also, as I said earlier, explain the symptoms of dying. So, if they're a bit agitated, explain that this is not uncommon at end of life, that people can get a little bit unsettled. We can give them some medication to keep them comfortable, and we can do that, via the injectable form. Explain to the family that people become drowsy and they're not able to eat and drink because they can't swallow, and that they don't have that feeling of being thirsty or hungry. So, we don't need to worry about the food and drink, and we just do the mouth care. So it's all just about, taking that time to really just make sure that they are understanding and comfortable with the care that you're providing. Symptom management, we'll talk a little bit more on the next slide about that, but we'll just talk to it when it comes up on the next one. Now, bereavement support. When someone's passed away or died, provide support to the family. Obviously, there will be, some people are more distressed than others, but they will be distressed at that time. Offer your condolences to them and explain the process from here. So let them know, speak with the family, let them know that, from this point they can stay for as long as they want with their loved ones. That's okay. Let them know that when they are ready, we can organise for the funeral director to take their loved one into their care. Talk to them about experiences you had with that person. For example, Ruth was always smiling and she always loved to play the games down in the activity room. Just make it a bit more personal if you've had some experience with them. Explain the verification of death. So explain to the families that needs to be attended, and what that process is. Also, obviously, the GP would need to know, and you organise all the paperwork and the funeral director when the family are ready for that. Attend to the after-death care. So when you do your post-death wash, speak to the person, speak to that resident. Their soul is still there. They're still in your care. So still speak to Ruth, who's in the bed, and just say, I'm just going to wash your back, and still be that soft and calm person. The other thing I would like to say, that the way we speak about death and how we speak about it, that language does really matter. So, the resident is still someone's loved one. So make sure you still refer to that person, the person with their name, still speak to them about their loved one with respect. Saying that the funeral directors will take Ruth into their care sounds nicer than saying the funeral directors will collect the body. It just is a little bit more kinder and gentle language. We tend to follow up, and I'm sure you guys do it in the RACHs as well, with bereavement support after someone has passed away. So we tend to send out like a card and some packs, but there is supports available. There's, NALAG, there's Grief Line. So just, the GP can also be someone who is a resource person if anyone's having any difficult coping, but just inform them and that there are help available if they need it in the future. All right, we might go on to the symptom management one next. Thanks, Hayden. Oh, bit dry. So I haven't talked about every symptom because there's, it's just mainly the main symptoms that we tend to come across at end of life. So the main one being pain. What I would say is to assess this often and look for both verbal and non-verbal cues for pain. Non-verbals, the moaning, groaning, facial grimacing, any unsettledness. I would say that if someone is at end of life and they're in the bed, they're bed bound, and they are not getting rolled as often because they don't need to be. But if you're lying in the one spot for extended period of time, I would say you would have some discomfort because of the fact that you're laying in the one spot. So I would encourage to give PRN, so those extra subcutaneous medications, prior to any kind of cares and movement, because I would argue that having been in one spot for an extended period of time and then to move would be uncomfortable for someone. So I would say give your PRNs prior to care and movement. And really, it's all about just aiming to really decrease any kind of discomfort that that person will have with our interventions. Also, utilise the PRNs when needed on top of that as well. The medications that we give at end of life are not going to cause the death of that person, that resident. It's the disease process, it's their frailty, their age, that is actually what's going to cause the death of the person. The PRN medications or the regular syringe driver medications is designed to give them a comfortable death. It's designed to manage the symptoms of dying. So giving the extra PRNs is not going to cause them to die from the medications. So just make sure you really utilise those medications if they're required. It's a bit like I, often think about morphine, midazolam. It's very similar to having, like, if you have a headache, you have Panadol. So in the symptoms of dying, you can be uncomfortable and agitated. So we give the morphine and midaz. So it's sort of the same thing. We give them something for that comfort. So obviously when you're progressing really to the end of life, you look at what medications they're on currently, whether pain medication wise, people are often on a long-acting medication, and converting that to probably a subcutaneous form of medications, because as you well aware, people, when they get to the end of life, they are unable to swallow. So we need to give injectable forms. So depending on what they've had as a background medication, they may need to go, onto a syringe driver sooner rather than later, just to keep that comfort level at what they're used to. And also the medications that we use really, it depends on their medical history. So if they've any renal problems, we might use more sort of hydromorphone. If there's any, generally, but it's probably more morphine that we utilise. So they're probably the two main ones. There are patches that we do use, fentanyl patches as well, that sometimes we can leave on and just still utilise the subcut medications as well. So main things for symptom management with pain is assess it often, utilise the PRNs, and advocate if it's not enough. So it could be charted as every 4 hours, but the patient has pain every 2 hours. Well, we need to do something about that. So advocate with the GP, talk to them and just say, look, we need to organise this or have that changed because of A, B and C. So be that advocate. Respiratory wise, so think about, I guess, positioning of what position the patient's in. If they're a little bit, low, or they can sit up a little bit with the back of the head. So you can bring the back of the head up, of the bed up a little bit. If they're having any kind of breathing difficulties, look at the air circulation in the room, maybe open some windows or put a fan in there. I would discourage any kind of suctioning. Some people might want to suction inside the mouth. With a yanker just at the side of the mouth, yes, maybe, but definitely nothing further. It would be very uncomfortable if you were to try and suction out, deep in the back of the throat. Reposition into a position that it might drain out naturally is what I would say. Oxygen therapy, not everybody actually needs oxygen at end of life. People, as they proceeding to the end of life, they're going to have naturally lower saturations, and it might not be distressing to them at all. So oxygen is not necessarily needed. However, some people may require it due to their disease process. Oxygen, it can dry your mucous membranes even more. It can also prolong the dying process, and you can get those pressure sores that are uncomfortable as well. So that's not necessarily required. If someone's having a lot of respiratory distress, you would utilize your subcut medication. So use the Midaz and the morphine, relax the body, and the breathing will settle with that. Now, noisy breathing is often something that occurs, and basically it's the phlegm in the back of the throat that's sort of a bit in no man's land. So you can't get to it from the top, and also the patient or the resident's too weak to cough and clear out their throat. And it's sort of the air going through that phlegm. So it's, as people are probably quite well aware, it can be quite distressing to hear that from a relative's point of view. Back in the day, it used to be that the glycopyrrolate, we used to give that to dry up the secretions. I would say that we don't routinely utilize that anymore, mainly because it doesn't just, may be effective, not great evidence that it will be, but it also is not that effective just on the secretion. So it'll dry everywhere else up as well. So we're talking eyeballs, mucous membranes, bowel, urine, everywhere dries up. So I would argue that it'd probably just be as uncomfortable for the patient, quite uncomfortable. So again, if there's any kind of distress with the noisy breathing, we would utilize those subcut morphine and Midaz, but explain to the relatives that often the patient in the bed is unaware that this is occurring and is quite comfortable, but it is something that can be distressing to those listening. It's okay for them to have a little bit of time out, have a walk away, as long as they're, you reassure them that this is not distressing to their relative at all. Now, nausea and vomiting, it can occur sometimes. Sometimes it can be medicine related. It might be disease process, an obstruction, constipation. You'd look at utilizing subcut medications depending on what the reason was for the nausea and vomiting. Meds we often use is more sort of haloperidol in the case of bowel obstructions, because it doesn't have that peristalsis movement like metoclopramide does. Otherwise, it's generally Maxilon that we use. There are other agents too, like cyclazine and domperidone, that you can use. It can be as a PRN, it can be put in a syringe driver. It just kind of depends on what's the reason, the cause of the nausea, vomiting. You can also do a syringe driver if there's no issues with nausea and vomiting without an antiemetic. That's totally okay as well. Now, bowels at an end of life, I'd say it's probably less concerning for us if the bowels weren't open for 3, 4, 5 days at end of life, when we're talking days of life left to live. Obviously, there's only 2 ways to get bowels cracking, and that's either orally, so from the top, or from the bottom. So when someone's at end of life, they obviously can't swallow, so the top end is no longer able to be utilised. And if it's not causing any distress or issues for the patient, I would say that you wouldn't worry too much about an NMR, because that can be quite uncomfortable as well. But if needed, you would give them some medications with the subcut morphine or whatever analgesia that they have for any kind of discomfort. Now, for agitation, sometimes people do get that terminal agitation. Agitation can also be caused by numerous other conditions. It can be pain, constipation, urinary problems. It could be their breathing, hypoxia. It could be the disease process. So it could be the dementia, or they might have some kind of a brain cancer or disease process going on there. Again, we generally use, subcut medications. Usually midazolam is sort of the drug of choice, really, but you can use haloperidol or lorazepam. Some people do have clonazepam drops that may be administered prior to end of life, and you can still give those orally. They can be absorbed buccally as well, but generally the most common is your midazolam as a subcut injectable form. And then lastly, I just want to talk about is personal care. So it's also very important to provide personal cares to the resident. So eye care, give their eyes a little bit of a wipe with sterile gauze and water, bit of mouth care, so inside with swabs, whatever you use. Some have been impregnated already with Zodibic on it anyway, or whatever your facility has, but regular mouth care. Lip care, you can use a little bit of Vaseline or paraffin, or they might have their own stuff anyway. Sometimes people quite often are mouth breathers, so you might need to do that mouth care more regularly because it will dry out more because they're obviously in and out with their breathing. If someone's a bit resistive, that's okay. Just try and do the bits that you can get to. So around the cheeks, you might not be able to get into the mouth, but still be able to provide some around the sort of inside of the mouth and the teeth. And they may, as they become more relaxed and more heading towards the end of their life, they may loosen in their mouth, and you'll be able to provide better mouth care as time progresses. And pressure area care, you don't need to do that, every 4-6 hours. You can do it a little less. We're less worried about skin integrity at that point. It's more about comfort. Often people nowadays are on air mattresses anyway. So the more you turn, the more discomfort you get someone. So just if you need to do personal cares, obviously you do need to roll, but otherwise I would say every sort of 6 to 8 hours if there's nothing sort of needing to be attended. And just reposition from, side to back to side as well with that. And
Gemma, sorry to interrupt. We've got a question.
Oh, hit me.
Hi, my question is regarding the respiratory management, the symptoms.
Yeah.
Can I just ask why Buscopan is not one of those medications that can be used or recommended in managing that kind of the death rattle towards the end of life?
Buscopan.
Yeah.
Yeah. I guess a bit similar towards the glycopyrrolate. I mean, you can use it generally with some of those medications. The later you introduce it, the less effective it would be as well, is what I would say. So things like hyoscine tend to generally use, or personally, I tend to generally use more for things like bowel obstructions rather than secretion issues with noisy breathing. So, I mean, again, it may or may not work, but it's not something that we would routinely recommend. More the repositioning and education.
Okay. Thank you.
No worries. Does anyone else have any questions or queries?
Just a query in our NPS, our GP is really reluctant to start syringe drivers without actually having a palliative care team or specialist involved in the care. I'm just wondering if other people have the same issue. Like I'm thinking GPs can do normal end of life management without having to involve a specialised palliative care team. Obviously, they're very busy as well, but I don't know if it's fear of being sued or something, but tends to think that every end-of-life patient in our RAC has to be seen by the palliative care team and not allowing normal RNs and experienced RNs and stuff to guide as far as syringe drivers and stuff. It's probably, I don't know if that's a common issue.
I think you're spot on. I think, Michelle, we used to see and service a lot of the RAC patients, but and it's probably not easy for the GPs, but I guess they respect the assessment and recommendations. But it is, if it's someone who is very like a simple dying, and you're right, you guys know it just as well as we do, or if not better, you know, you can manage that. We're basically more for difficult symptom management, more for, I guess, sort of like that next level of dying where it's difficult to manage just within that area. I mean, I think it's probably has been that, and I guess it's been a bit of a change where we're, you know, we're not building up, but allowing you guys to do what you're good at, you know, in the RACHs, and you are good at end of life care, and you do know what needs to happen. And when it's something that's just that simple dying, which is a funny term, but you know, you are just as experienced as we are.
Thank you, Gemma. I'm going to thank you on behalf of our participants. I'm Anne Burns, who I've come in late. Hayden carried the flag for us, for the PHN. I want to thank all participants who've attended today. And on the final slide, if you could grab out your phones and complete the QR code evaluation form. It's very quick, and we do get a lot of information from your feedback about the sessions, which helps us prepare for next session. So if you could grab your phone out or your iPad and scan the QR code and complete that very simple evaluation, it is very, very helpful for us. And I'd like to thank Gemma and thank her for her valuable information and input, and we welcome all participants to our next two presentations, which you will be hearing about, which is again presented by a very skilled palliative care team within our Western Area Local Health District. And on behalf of everyone here, I'd like to thank Gemma.
Thanks, Anne.
Thank you.